Hello again. Is the last time you'll see me today. So it's, unless you come for the opening session. So what I will do, I will talk a little bit on heart failure. And actually we have had some disappointing results, and we'll try to understand why that has happened and what is the future. I have to say that we have had an era of outstanding results in treatment of heart failure. Mortality went down with the introduction of different drugs, but we still have patients where mortality is pretty high. You see, with chronic heart failure, mortality is around 6% per year, which is not too bad. For de novo, still 20% per year. And with worsening is 27.7%. So basically a mortality that is higher for most form of cancer. And that is even higher if you take acute heart failure. Since 2000, we had a lot of studies that were positive and showed efficacy of different type of drugs, but with beta blockers. We had the seniors with nebivolol. And then we had the intervention studies with surgery. We had data with mineralocorticoid receptor antagonist, with ivabradine, and with LCZ696, all of which reduced mortality down to 5.6%. Now, regarding new drugs, there is this issue what we discussed this morning, whether we need to go on mortality or we need to go also on functional capacity. And one theory was the fact that iron may be relevant for cardiovascular disease. And of course, there is the issue that dietary iron basically is useless. And the reason is that if you have, say, a depleted iron storage, that means that you need at least between 200 and 400 milligrams. So if you give iron by mouth, then what you get is no more than 2 milligrams per day. So it takes you at least 2 years in order to restore the depleted iron. So the only way of giving iron is intravenous, and there was a trial that first tested this hypothesis, therefore was the FAIR-HF study that looked at the effect of intravenous ferrocarboxymaltose on 6-minute walking test and quality of life. The study was positive. It was followed by CONFIRM-HF, a study that looked specifically at iron infusion in patients with iron deficiency, but without anemia. What is important is that there's no correlation between anemia and iron deficiency. Iron deficiency, if you give iron, iron has an effect both in patients with anemia, but also in non-anemic patients with iron deficiency. So this is an important point, and there was a significant effect on exercise capacity with intravenous iron. Now there was a trial that was just completed. There is the iron out with oral iron that was completely negative, but the reason for this is that if you give oral iron, you cannot restore the storage of that you need and the amount of iron that you need in order to increase muscular metabolism. Then we have the trial that is ongoing with iron that just started, is the AFFIRM-HF, and will recruit 1,100 patients with hospitalized for acute heart failure. They will be followed for 2 to 3 years in order to see whether there will be an effect of intravenous iron on cardiovascular mortality and morbidity. We have to wait for that. Besides that, apart from the AFFIRM-HF, there is an NIHR sponsored study in the UK. It's called Ironman, that basically looks at more or less at a similar effect on with the different forms of IV iron. in patients with chronic heart failure. So these 2 trials will be completed in a couple of years. The other possibility of trying to improve cardiac function in heart failure is through inotropic drugs. I feel that this is not the right way to go, because it's if you give any inotropic agent, that will work in the short term. In the long term, will lead to a depletion of ATP, which in turn induces an increase in calcium and therefore more arrhythmias. And most of these studies have been stopped in long term. So we know that, for example, the pulse infusion of dobutamine in patients with chronic heart failure is not effective. We know that digoxin is not effective. We have data on trials showing that. Levosimendan also is not effective in improving long-term prognosis. And we have had disappointing results from gene transfer with Medicar, that was an intracoronary infusion of gene therapy that basically failed the phase 2 trial. One trial that is still that just started is with Omecamtiv Mecarbil. This is a drug that is a cardiac Myosin activator. Basically increases the interaction between actin and myosin and increases contractility. So increases the duration of systole, increases stroke volume, and without any increase in myocyte calcium. What is important, it seems that it doesn't increase oxygen consumption. A phase 2 trial showed in healthy volunteer and in patients with heart failure a good improvement in left ventricular function, stroke volume, fractional shortening, and ejection fraction. So there are good possibilities that this intervention will work. And the Galactic HF trial was just started in January, and will aim to include 8,000 patients with heart failure to determine whether Omecamtiv Mecarbil is effective in reducing the composite endpoint of cardiovascular mortality and hospitalizations for heart failure. The other class of drugs that are of interest in heart failure are the SGLT2 inhibitors. And these are basically smart diuretics. There's no difference from other diuretics, but they just exchange glucose rather than sodium. But apart from that, what is important is that in the EMPA-REG study, they reduced mortality by 30%. This is the first drug in diabetes that reduces mortality since the UK PDS conducted 27 years ago. So a lot of waste of money in diabetes to look at for drugs that may have an effect, a lot of waste of money on drugs that do nothing in patients in diabetes with little effect on glycated hemoglobin, yet they are very well perceived by our colleagues diabetologists. This drug seems to be effective and seem to reduce by 30% hospitalizations for heart failure. And there are 2 trials currently ongoing and start recruitment. One is with dapagliflozin, and the other one is with empagliflozin in patients with chronic heart failure with and without diabetes, in order to establish whether empagliflozin or dapagliflozin will improve cardiovascular endpoints. Other phase 3 trials are the Commander HF with rivaroxaban, to see whether anticoagulation with rivaroxaban will be effective in reducing mortality and morbidity. We had significant results with rivaroxaban recently, patients with coronary artery disease and peripheral arterial disease. So it will be important to see whether this hypothesis is also true in patients with heart failure. And the Victoria trial with vericiguat, and that will look at the effect of activator of guanylate cyclase. The Commander trial, basically, it will include 5,000 patients with symptomatic heart failure, elevated BNP, and recent exacerbation of heart failure. And the results are, the trial started in 2013. Recruitment should be completed by the end of the year or mid next year, and we will await for the results. The other possibility to try to improve cardiac contractility is we know the effect of LCZ696. We know that, that you can do the same, you can activate through ularitide, but also you can activate the guanylate cyclase with riociguat and vericiguat. Riociguat has failed in previous trial, and vericiguat more recently showed basically no significant effect in reducing the NT-proBNP in patients with heart failure, and there are doubts whether there will be any further study on that. Other new treatment areas are acute heart failure, mid-range ejection fraction, and preserved ejection fraction. In preserved ejection fraction, there are no drugs that work. Neutral effect from CHF with perindopril, with candesartan and irbesartan, and with spironolactone, with modified dose of spironolactone. Now, after the results of LCZ in 696 and Paradigm-HF, Novartis has started the Paragon-HF trial that will compare the effect of LCZ 696 compared to valsartan. I think is a risky trial, because if it shows that there is an efficacy, that means that the only effective part of LCZ 696 is sacubitril and not valsartan. So I don't think I cannot see the rationale for conducting a trial like that rather than to placebo, given that there are no other therapies in that therapeutic area. The other area where we need therapies is acute heart failure. But acute heart failure is a condition where you have patients that present with pulmonary edema, systemic congestion, and organ dysfunction. The problem is that most of the studies have focused on pulmonary edema, and pulmonary edema is something that, and dyspnea. And dyspnea is something that you see in the emergency room, and by 6 hours, patients are treated, and often 60 to 70% do not have dyspnea. Whilst trial that looking at these drugs in this area looked at the effect of any infusion in patients that have been hospitalized in the past 48 hours. There was, I've discussed this morning about relaxin. As you remember, there was a suggestion that there was an effect on the area under the curve of the visual analog scale, but there was no effect in another scale. There was the Likert scale that had been used in the phase 2 trial, and that basically was the base for the RELAX study. And 2 weeks ago, the RELAX-HF2 data have been released, and basically there was no effect whatsoever of relaxin in patients with acute heart failure. Another natriuretic peptide is ularitide, urodilatin, and that is secreted by the kidney, but it's similar, very much similar in terms of efficacy, of effectiveness to BNP or ANP. And the TRUE-HF study has been recently presented at the at the Heart Failure Association meeting, and basically showed that overall there was no effect of of ularitide in 2,100 patients with acute heart failure. Then they looked at the design of the study was interesting, because they were looking at a sort of hierarchical endpoints, looking at basically at the heart failure global assessment, at the worsening heart failure, death, but also on the effect on use of inotropes or systemic need of mechanical support. And these are the data that were been presented 2 weeks ago: neutral, no effect, no improvement in mortality. One important point was on the eligibility of patients. They looked at those patients who were protocol violators because were not eligible, and you can see that those who were eligible, they found an effect of superiority of ularitide. Of course, this is hypothesis generating. because the trial is negative. So in conclusion, there are no new drugs that have been proven effective in acute heart failure. This is probably due to the fact that we are not assessing the correct endpoint and we are not using the correct approach. So probably we need to look for new different areas or to better phenotype patients in order to succeed in acute heart failure. Thank you.